Hi everybody, this is your first lecture for Nursing 203, and it is going to cover the basic acid-based balances. And actually this is chapter 14 in your IGGY book, and it should be a little bit of a review before we get into actual lecture and start talking about specific acid-based imbalances. So acid-based imbalances are actually the result of processes that carefully regulate hydrogen ions, their production and elimination from the body. And body fluid pH is a measure of the body's free hydrogen ion level. This normal level should be 7.35 to 7.45, and if it is not that, it can interfere with normal bodily functions. And how it actually interferes is by these different mechanisms. So it changes the shape of the hormones and enzymes so that they no longer perform normal functions. It changes the distribution of electrolytes, causing fluid and electrolyte imbalances. And it changes excitable membranes, which makes the heart, the nerves, the muscles, and the GI tract less or more active than normal. Finally, different blood pH levels actually decrease the uptake, activity, and effectiveness of many hormones and drugs. So to introduce you to a little bit of the acid-based chemistry, we want to talk about acids. And acids are the substances that release hydrogen ions when they're dissolved in water. And bases, on the other hand, are what actually substances that bind to free hydrogen ions in solutions. So they are actually the hydrogen acceptors, and they lower the amount of free hydrogen ions in the solution because they bind to them. Buffers, on the other hand, are substances that are capable of binding or releasing hydrogen ions into bodily fluids. So they can actually kind of do both, and they're very critical in keeping body fluid pH at normal levels. So they actually, through both mechanisms, try to keep that body fluid pH at 7.35 to 7.45. Body fluid chemistry actually is the next thing we will talk about, and that is a little bit different than your acid-based chemistry. Body fluids actually contain many different types of acids and a few types of bases. The most common base in the human body fluid is bicarbonate, or HCO3. And the relationship between carbon dioxide and hydrogen ions is very important in body fluid chemistry. The key concept in understanding them is the carbonic anhydrase equation. And that is actually driven by the enzyme carbonic anhydrase, and it shows how hydrogen ion levels and carbon dioxide levels are directly related to one another, so that an increase in one actually causes an equal increase in the other. So they're kind of directly related, and you can remember them in that way. The different sources of acids is what we will actually talk about next, and whenever acids are present in our bodily fluids, free hydrogen ions are disassociated and must be controlled so that our pH can be balanced. So how are they actually controlled? They can be controlled through different mechanisms. So normal metabolism is one of those, and that includes glucose and fat and protein metabolism. The incomplete metabolism of glucose and fats is another, and that occurs when cells metabolize under anaerobic conditions, which we have no oxygen in, and they actually form lactic acid. Some of those situations would be your sepsis, your shock, your hypoxic situations. And then the third one is your destruction of cells. And that actually allows cell contents to be released. So when this destruction of cells happen, cell structures actually contain acids. And then when those acids are released into the extracellular fluid, free hydrogen ions become disassociated. So the different ways that our respiratory acid-based control mechanisms work is through hyperventilation and hypoventilation. So when chemical buffers alone cannot prevent changes in our blood pH, and we were talking about those buffers, they can work through two different mechanisms. The respiratory system kicks in, and it's our second line of defense against any acid-based changes. So the first way that our respiratory system works is through hyperventilating. And in hyperventilation, we all know that the rate and depth of our respiration increases. So we're tachypnic, we're blowing off of all of the carbon dioxide and decreasing that extracellular fluid concentration of carbon dioxide. In another way, we can actually hypoventilate, and that will control our blood fluid pHs as well. So If the extracellular fluid hydrogen ion concentration is too low, we decrease our rate and depth of respiration, and less CO2 is going to be blown off, and more CO2 is going to be retained in our arterial blood, correcting that pH. And this picture will show us a little bit of the neural regulation of our respiration and hydrogen ion concentration. It is kind of a review of what I just talked about, but it's in a different format, so you can view it a little bit differently in this. But respiratory regulation of acid-base balances is under the control of our central nervous system. So special receptors in our respiratory areas of the brain are sensitive to any changes in carbon dioxide in the brain tissues. As the amount of carbon dioxide begins to rise, if it's above the normal level in our brain, blood, and tissues, the central nervous system receptors actually trigger neurons to increase the rate and depth of breathing, which we were talking about our hyperventilation. And then as a result, more carbon dioxide is exhaled or blown off from the lungs, and the amount of carbon dioxide in the extracellular fluid decreases. So when the amount of arterial carbon dioxide returns back down to normal, the rate and depth of breathing actually turn back to normal for that person. And in the same way, the body hypoventilates as the central nervous system senses those different changes in carbon dioxide and blood pH. So how does the renal acid-base control mechanisms work? Actually, the kidneys are the third line of defense against any changes in body fluid pH. And the kidneys actually work in several different ways. So first, the kidneys actually move bicarbonate, or they make additional bicarbonate and reabsorb it into the body for an increased buffer effect. And when blood hydrogen level ions are too low, the bicarbonate remains in the urine and is excreted. So our kidney kind of helps us out in that way and works to control those pH levels. As the formation of acids work, acids actually draw our hydrogen ions into the urine, and they're excreted in our urine. So our renal system senses those acids and gets them out of our system. The other way that the renal acid-base control mechanisms work is that they trap hydrogen ions and allow them to be excreted in the urine. And this is through the formation of ammonium. And the loss of hydrogen ions will equal an increased blood pH as this ammonium is formed and hydrogen ions are trapped and excreted in the urine. So compensation is something that we will briefly hit on, and we will talk about in lecture again, and we will actually do some examples where you'll have to determine whether or not the body is compensating, and it's actually not as complicated as you may think. So we will obviously talk more about this because there's a lot of maybe confusing words in this lecture that I wanted to introduce you to, and definitely refer back to your book if you're getting confused with those words. But compensation is when the body attempts to correct changes in blood pH. So we were talking about how the respiratory system and the renal system make changes for us naturally, and that is part of compensation. So if our respiratory system actually senses any changes, acid-base changes, it will begin compensation efforts within seconds. Respiratory system is very quick. The renal system, on the other hand, their mechanisms that they work with are much more powerful, and they result in rapid changes in the extracellular fluid composition, but they may or may not be triggered for several hours to days. So the renal compensatory mechanisms actually take a lot longer than the respiratory mechanisms. And if we want to look at those pH levels, any pH levels less than 6.9 or greater than 7.8 are usually fatal. This diagram just shows us a little bit of how our body compensates. So we know that our kidneys function to change those bicarbonate levels in the body, and our lungs function to change those carbon dioxide levels in the body. And so when we think about our lung function, we know it's rapid response, but it's very limited. And we know that the kidney is a very powerful response, but it's very slow. So we kind of hit on this already, but respiratory compensation is when the lungs compensate for acid-base imbalances of a metabolic origin, and respiratory efforts actually cause the blood to lose carbon dioxide with each exhalation, so that extracellular fluid levels of carbon dioxide and hydrogen ions decrease. and that will bring our pH level back to normal. And when we start giving you examples of these after lecture and you'll get to work with them, I think it will start to make a little bit more sense to you how this compensation really works. Renal compensation is when healthy kidneys can correct or compensate for changes in blood pH when the respiratory system is either overwhelmed or is not healthy. So when we think of what can make the respiratory system not healthy, it would be your pneumonias, your patients with chronic COPD, those patients maybe that are having difficulty breathing, asthma is going on. The body may renally compensate for that because the respiratory system is overwhelmed and not working normally. So the kidney then excretes more hydrogen ions and increases the reabsorption of bicarbonate back into the blood, allowing the pH to return to normal. So what we do as nurses when we see patients with acid-based imbalances is take a very accurate history. And the chart on page 202 in your IGGI book, chart 14.3, is very good, and it gives you actually nursing focus, what you would focus on when we're obtaining a patient's history that we're expecting in acid-based imbalance. So we're going to want to assess risk factors. So drugs, chronic health problems, kidney disease, pulmonary disease, acute health problems are going to be very important to assess for. We want to obtain a history when the patient's awake and familiar with their surroundings, they're oriented. We want to ask the patient to list prescribed and over-the-counter drugs. So if they're on any diuretics or antacids, those can affect our acid-based balances. And we also want to ask the patient to recall what liquids they have taken or if they've been urinating normally. So all of those kind of normal things, but all those things that will affect our acid-based imbalances are important to gather when we're gathering a patient history. When assessing patients, we want to obviously compare the mental status, so our level of consciousness, is that baseline for the patient or is that abnormal? And then observe their rate and depth of respiration. We've talked about how the respiratory system can compensate and can increase or decrease our rate of breathing. And that will be important to assess when you're going into these patients' rooms. We're going to want to examine the color of the patient's nail beds, mucous membranes. Urine specimens are very important to gather, and then testing those for pH levels and specific gravity. Assessing the skin turgor and those dehydration. Is the skin dry? Is it flaky? Are they sweating? What are they in the hospital for? And how does their skin look and how do they look in general? Measure the rate and quality of their pulse. Observe their clinical responses and lab values. So we will probably be getting arterial blood gases on these patients, and we are going to want to monitor that serially. So we want to get those initially if they're having difficulty breathing or we're expecting an acid-based imbalance, and then we want to get those afterwards to compare the values to if we've done any interventions. So that's kind of a basic history you want to gather and a basic assessment. And there are several key features. There's some charts in your book. So chart 14.4 in IGGI and chart 14.6 in IGGI actually give you some key features of acidosis and alkalosis. And we will go over some of these in lecture, but I just wanted to kind of give you an overview of the key features. So for a patient with acidosis, you may see some cardiovascular signs and symptoms. And these can include tall T waves, and that may be from hyperkalemia, because they will have some fluid and electrolyte imbalances. We may see bradycardia. The patient may have heart block, a widened QRS complex, and prolonged PR intervals. And as I was saying, these cardiovascular signs and symptoms can be caused from some of those acid-based imbalances and electrolyte imbalances that we're going to be seeing. The patients could have hypotension, thready pulses, central nervous system. Signs and symptoms could include confusion, stupor, coma, lethargy, and then some neuromuscular signs and symptoms. They could be very hyporeflexia, so they could have very decreased reflexes, skeletal muscle weakness could be common. Respiratory signs and symptoms are going to be tachypnea. You may see those Kussmaul respirations, those deep, rapid respirations, and you may see kind of variable respiration. So like we were talking, they could be hypoventilating or hyperventilating. And then you may see some warm, flushed, dry skin if these patients are in metabolic acidosis. And you may see some pale, cyanotic, or dry skin in respiratory acidosis. When we talk about our alkalosis, the key features are a little bit different. And as I said, we will go over these in lecture, but I want to give you a brief kind of introduction to them. So central nervous system signs and symptoms in alkalosis are your increased activity, your anxiety, irritability. They may have tetany, seizures. They may have a positive Trousseau sign and a positive Vostek sign. And as we know, that would be from our calcium level being low. So you may see that calcium level low and those changes. And then in our neuromuscular manifestations or signs and symptoms, we're going to see those same things that we will see with the patients that have hypokalemia and hypocalcemia. So hyperreflexia, muscle cramping and twitching, skeletal muscle weakness, cardiovascular signs and symptoms could be your increased heart rate. They may have a normal or may have a low blood pressure, and they have a higher incidence for digoxin toxicity. So that's important to remember as well. Respiratory manifestations with alkalosis are a little bit different, and they may have an increased rate and depth of ventilation in respiratory alkalosis, and they may have decreased respiratory effort associated with that skeletal muscle weakness if they have metabolic alkalosis. So those are some of the overview of the physical assessment parameters that you may see and you may be looking for in patients with acidosis or alkalosis. And basically they're caused by the excitable membranes basically responding to acid-based imbalances and changes in our fluid and electrolytes. So this is the diagnostic assessment that you will generally see in patients with ABGs or arterial blood gases that is drawn directly from an artery. It's usually an artery in the wrist that they draw ABGs from, but it can be from a femoral artery as well. And the levels that you're going to be looking for are going to be your pH. Normal levels for a pH are 7.35 to 7.45. Your PaO2, or your oxygen, and that's normal levels will be 80 to 100 in your ABGs. Your PaCO2, normal levels will be 35 to 45, and that is pretty easy to remember because if you look at your pH, 7.35 to 7.45, your CO2, 35 to 45. So basically that's how I remember those two. And then your bicarb levels are going to be 21 to 28. So you will see different ones probably in different hospitals, and we'll kind of go over the normal levels that I want you to know and how you'll have to analyze these different levels and determine basically what acid-based imbalance is occurring. So there are some things in that right column that give you a clinical significance of increased and decreased levels, but when we start to lecture on these and go over examples, that will start to come together for you. The last slide here is just something that I wanted to give you briefly before we go into lecture on Monday, but acidosis and alkalosis are a little bit different. So if you can remember that acidosis actually is associated with a pH that is low, so less than 7.4. Acidosis is the pH is sliding down. The D in that doses may tell you that it's sliding down. Alkalosis would be your pH is high, so greater than 7.4. You can think of that as your alkalosis, the pH is being kicked up. So that is kind of a short little thing that I wanted to go over and introduce you to. And we will talk more about this in lecture and get into some examples and let you start working with analyzing ABGs. Hopefully you have a good day, and I will see you for the beginning lecture on Monday.